Good afternoon, everyone. Welcome to Critical Condition, a discussion on Black health in America. In advance of the PBS broadcast premiere of the new Nova and Firelight Films documentary, Critical Condition Health in Black America, today we will hear from the filmmaker and experts for a timely discussion about the factors behind the health crises facing Black Americans. My name is Ralph Bouquet, and I am the Director of Education and Outreach for Nova, the PBS science documentary series produced at GBH. And I've had the incredible pleasure of working on this film alongside the team at Firelight Films for the past few years. Critical Condition is a film that investigates the factors behind health disparities in the US, tracing the historical roots of false beliefs in our medical system about Black people and examining the environmental conditions that contribute to disproportionately poor health outcomes for Black Americans. Here are some hard truths. Black Americans are nearly twice as likely to have high blood pressure, diabetes, and heart disease than white Americans, and their life expectancy is about 5 years shorter. Black women face some of the worst maternal health outcomes in the US and are 3 times more likely than white women to die during pregnancy and childbirth. Nearly a quarter of all Black Americans in this country live in close proximity to pollution emitting facilities or one of the nation's 1,800 toxic Superfund sites, linked to higher rates of infant mortality, cancer, and lung and heart disease. Critical Condition seeks to answer one question: why? Over the next hour, we will explore how this question is answered in the film with an incredible panel of filmmakers, historians, public health experts, and doctors. First, I'd like to begin by introducing the director of Critical Condition, Oscar-nominated and Emmy Award-winning filmmaker, Stanley Nelson. Stanley Nelson is today's leading documentarian of the African American experience. His films combine compelling narratives with rich historical detail to shine new light on the underexplored American past. He is the recipient of a MacArthur Genius Fellowship, 5 Primetime Emmy Awards, and Lifetime Achievement Awards from the Emmys and IDA. His latest films include Critical Condition, Health in Black America for Nova, which we're proud to note is his first science film, and We Want the Funk, which premiered earlier this month on PBS's Independent Lens and is now streaming via PBS and the PBS YouTube channel. Stanley is also the co-founder of Firelight Films, the production company behind Critical Condition and the Oscar-nominated documentary Attica, and the nonprofit organization Firelight Media, which is celebrating its 25th anniversary this year. I'd also like to introduce Dr. Chandra L. Ford, who is professor of behavioral, social, and health education sciences in the Rollins School of Public Health and jointly appointed in African American Studies at Emory University. Dr. Ford's research addresses the persistent and pernicious impacts of racism on individual and population health. She's the founding director of the Center for the Study of Racism, Social Justice, and Health, which was launched at UCLA, and she is lead editor of Racism, Science, and Tools for the Public Health Professional, APHA Press 2019, which the American Library Association named an outstanding academic title for 2020. Much of her work is dedicated to studying the impacts of racism and inequities on public health and supporting interdisciplinary research to prevent and combat the consequences of racism. I'd also like to introduce Dr. Evelynn Hammonds, who is the Barbara Gutman Rosencrantz Professor of History of Science, Professor of African and African American Studies, and Professor of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health at Harvard University. Her research focuses on the history of scientific, medical, and socio-political concepts of race, gender, and sexuality in the histories of medicine, science, and public health in the United States, Black feminist and queer theory, and the history of disease and race. Professor Hammonds is the director of the Project on Race and Gender in Science and Medicine at the Hutchins Center for African and African American Research at Harvard, and she recently served on the President's Initiative on Harvard and the Legacy of Slavery and on its advisory committee. And finally, Dr. Elaine Batchlor is the Chief Executive Officer of MLK Community Healthcare, a hospital and health system that provides quality care to 1.3 million residents of the medically underserved community of South Los Angeles. Her career has been devoted to expanding healthcare access, improving quality, and improving the health of vulnerable populations. She is a University of California Regent, a member of the National Academy of Medicine, and an advisor for the Duke Margolis Center on Healthcare Policy. her membership on the policy committee of the American Hospital Association, and service as a director on the board of the California Hospital Association provide insight and influence on behalf of safety net communities statewide and nationally. And I'd like to thank all the members of the panel for joining us today. Welcome, everyone.
Pleasure.
Yeah.
Thank you all so much for joining us. And we are just very, very excited. This is such an important film and timely film. And premiering tomorrow evening at 9 p.m., available to stream on the pbs.org Nova website. And I just wanted to first begin the conversation starting with Stanley and really wanted to hear from you all on your motivations and your interest in this work. And particularly with Stanley, I'd like to first ask, when Nova first proposed the idea of this film to you, why did you want to make this film, and why do you feel that this is such an important story to tell?
Well, obviously, healthcare is important to everyone, and our health is super important. And I hadn't seen anything like it, and some of the things that Nova talked about, I didn't even realize some of the science behind the inequities in healthcare. So it was just, a fascinating challenge for me and for Firelight to be involved in this film and to make it come to life.
Thank you so much, Stanley. And to the rest of the panelists, I'd love to hear, the issue of racial health disparities, their connection to history, their connection to the current social and economic reality of Black Americans is central to so much of the work that you all do. What has motivated you all to do this work? And let's start with Dr. Ford.
Thank you. For so long, there have been these disparities, and it is really in part, the narrative that has existed around what the causes of those disparities are. For me, professionally, in terms of why it's important that this film exists, is that generations of what we might call public health elders have been doing this work, often without recognition of the importance of the work and its implications. So there has been a growing body of evidence that demonstrates that the inequities that we see are actually tied to racism, scientific evidence. And for me, it's important that the film be made in order to reveal that, to offer that narrative to our communities.
Thank you, Dr. Ford. Dr. Hammonds, Dr. Batchlor.
So, just as Dr. Ford said, I think one of the things that drew me to this work, in fact, is both personal and professional. I grew up in the South. I grew up in a small. My parents grew up in a small town outside of Atlanta. I grew up in Atlanta, and there were clearly throughout my entire life there real issues around the kinds of healthcare that Black people received in Atlanta. I was curious about it, but I didn't really have a framework for thinking about it until I came to study the history of science at Harvard. And one of the first things I ever wrote about when I was a graduate student was what was happening to African American women during the AIDS epidemic, in the early days of the AIDS epidemic. And as I began to investigate that, I thought, well, wait a minute, this is not a new story. The ways in which African American women were being ignored, invisible in the epidemic that was actually really ravaging our community. And so I thought, as studying to be a historian, I have to look backwards. And that's when I began to look backwards into the 17th century, 18th century, 19th century, throughout the 20th century. And you can see African American peoples have always been subject to health disparities in this country. It's a very old story. It's a very troubling story. And so my personal interest in trying to understand something I couldn't quite understand growing up in Atlanta, but once I began my academic work in the history of science and medicine, it was very clear that we have an unequal healthcare system.
So as a physician, I have always been interested in addressing the needs of populations and improving population health, in addition to addressing the needs of individuals. And I also have a background in public health, which contributes to my view of how important societal drivers of health are. As the CEO of a hospital and health system serving an under-resourced community, my primary mission and goal is to improve the health of the community. And in order to do that, we have to understand these larger systemic drivers of health. We have to understand them, we have to identify them, we have to make them visible. And I think that the film is an important tool for making people more aware of the issues that we need to address in order to improve the health of our entire population, including the disparities that we see in underserved communities like ours.
Great. Thank you all so much for those thoughtful responses. I'd like to transition now to our first sneak peek from Critical Condition that examines the history of pseudoscience about race that has impacted medicine, and also the historical role that Black doctors have played in the past in both in challenging these racist assumptions in medicine, and in helping to pave a more sort of equitable way forward. And so we'll watch this first clip, which is looking at the history of racist pseudoscience and its impact on medicine. All right, thank you all so much. So in this clip, we saw one example of how science and medicine were used in the past to reinforce the racial hierarchy of chattel slavery in the U.S. With the creation of drapetomania. And I'd like to hear from the panel in what ways do we see now can racist beliefs about Black inferiority continue to impact the quality of medical care that Black Americans receive today, and their health outcomes.
Well, I'm sure that my colleagues are going to talk about the fact that there is a very robust body of research that shows that attitudes and biases impact the quality of care that's delivered, the trust that's established with patients, and the quality of care that patients receive. That those are very important drivers of some of the disparities that we see in healthcare. So it's the more modern version, I would say, of the illness that was named. And we know that we all have biases. Studies have shown that doctors and nurses have the same biases that others have, and that they do impact the care that we deliver. One of the largest studies ever done looked at 1.8 million births in the state of Florida and found that Black babies were more likely to survive if they had Black pediatricians. And it's that kind of research that we know we now have that shows that this has a very real impact on our communities.
So I would argue also that, when we think about the ways in which certain ideas and beliefs about innate and fundamental differences between white bodies and Black bodies, which has led to this persistent situation of health disparities in the United States, is a really, really important one. Because certainly it was even in the 18th century, we have white observers saying that Black people do not experience pain the same ways as white people do. That notion became deeply embedded in medical theory and practice. It's not, and it really isn't, I think, necessarily that we need to call that pseudoscience, that it's not science. It was the science of the day for the people who were doing that work. And therefore, this idea it was expressed by medical leaders in medical schools. Generations of medical students were taught this. And then we know as late as the 1990s and into the 21st century that medical students still have a sense of this, believe this. And that means they're still being taught that in many ways, that Black people and white people experience pain differently. And so That leads to misdiagnosis. It leads to physicians discounting what African American patients say about their condition at particular points. It also affects how people are medicated for pain. And so these ideas were, uh, while they were persistently challenged by Black doctors, nurses, and public health experts, they still became deeply lodged into medical textbooks and medical education in a way that then makes them consistently show up as being part and parcel of how Black peoples are treated today.
That important work on history really informs a lot of the thinking that scholars have today. If we think about, for instance, the ways that new technologies are being taken up, presumed to be racism free, and we know that that's not true. It raises questions for us based on what we have seen in the past about how we might anticipate the need for new strategies to respond to these 21st century um, forms of racism, the emerging forms of technology that are likely, and in some cases are already contributing to inequities in accessing care, and also in quality of care.
To give another example of how that actually gets embedded in technology, we use treatment algorithms in medicine, and we actually have algorithms that say, do different things depending on the race of the patient. You take an algorithm like that, which is not based on valid science, and then put that into, something that's driven by artificial intelligence and technology. And now you've just perpetuated it in a more modern context.
Thank you all for that. Just a quick follow-up question for Dr. Hammonds. You've done some work on Harvard's research on sort of the legacy of slavery, and in the film we do dive a bit into sort of the legacy that many of these really prominent, institutions, prominent journals, sort of their contributions to creating some of these foundational ideas that have then found their way into medicine and have impacted health outcomes. Can you speak a little bit more as to sort of the impact of that research in shaping our current understanding of the ways in which these beliefs continue to impact medical decisions?
So, I mean, I think what's important to know about that history is certainly in the 19th century, a medical school like Harvard Medical School, but not only Harvard Medical School, were really interested in a question that was a central question for them. How do you understand bodily differences between these human groups? And what do those differences actually mean? And they did a lot of work in comparative anatomy, raising different questions about physiology. Anatomy was one that was very interesting. I would argue that there wasn't a body part that wasn't measured and compared from one race to the other. And sometimes when I talk about it in my classes, the students are really shocked at this. But this is the core of the matter. They were working inside of a question that said that these people of different colors and hair types and eye shape and nose shape and certainly also intellectual capacity are fundamentally different. How do we figure that out? How do we understand it? So by the middle of the 19th century, it was intense work by many leaders of American medicine, but certainly biology and what became the new anthropology. They were trying to figure out what these questions were. Measurement was a way to do it. To say, well, we see that the Negro foot is always flat and the white foot is not flat. I mean, those kind of things, students will laugh at that one, but it gets deep, it raises questions that are much deeper than that. But once you set up a system where you're constantly comparing and constantly emphasizing that they wanted to understand a really particular specific kinds of questions. These were not just being asked by medical educators and physicians in the American South during the time of chattel slavery. They were also being asked by medical educators and physicians in the North as well. And therefore, this became a really legitimate aspect of medical education throughout the 19th century. And certainly for Black leaders and physicians particularly, uh, began to investigate these questions, they began to see the ways in which those questions were being answered. What are these differences and what do they mean? They saw the ways in which they were biased and that people were really, really ingesting their own ideas about bodily differences into the measurements they were taking, the questions that they were asking, and the answers that they decided were true. And the bottom line, by the end of the 19th century, for them, these biological, physiological, and anatomical differences were real and fundamental and would never change. And so that became something that was, I would argue, wasn't very much questioned. And then when public health experts began to do their work in the early 20th century, they were carrying those same notions forward. And of course, what they were doing was turning to something that they thought was biological and physiological and ignoring the social conditions under which people lived.
Thank you for that, Dr. Hammonds. A follow-up question for Stanley. You've done so many films documenting different aspects of Black American history. Was there anything that stood out to you during the filmmaking process of Critical Condition that surprised you about a belief or just a finding about sort of the impact of these ideas on current medical practices and the current health outcomes that Black Americans see today? Oh, Stanley, you're muted.
Sorry, I think as a lay person, I'm not a doctor. It was just shocking that these notions and ideas have carried over till today, and they are still being taught, and we're still reacting to these ideas that are still carried over to today. Also, that the science has proven that these ideas are carried over and that these ideas are still with us. So I think that when we started doing research, we were kind of shocked that there was so much science behind it, and so much real evidence behind some of these things.
Dr. Batchlor, Dr. Ford, any additional thoughts from you all?
I think it's important to recognize if we think in terms of the Sankofa concept for African Americans and people of African descent, that there have always been people within these fields, primarily African Americans, who have been fighting back and pushing back in order to honor the lives of African American people. In this moment, somewhat unrelated point that I do think is also important to consider is that we're now in a moment within the field of public health and also within medicine where our institutions name racism explicitly as a public health problem. More than several hundred have across the nation named racism as a public health problem. And so it's interesting that it is precisely as we gain solid footing in this knowledge base that the knowledge base is actually being contested, that research in this area is being contested. So I think it underscores how important this work is, not just as intellectual inquiry, but because it has real impact on the lives of people in our communities.
Great. Thank you all so much. And so now I want to transition quickly to another clip from the film. And this clip examines sort of the current reality and the socioeconomic determinants of health that Black Americans face today, particularly with regards to access to healthcare. And so, in this next clip, we're actually going to examine the community that Dr. Batchlor works in, where she serves as the MLK Community Healthcare CEO in South Los Angeles. Thank you for sharing that clip. And so I guess we now turn to sort of the current reality. And I'd like to ask the panel, what are some of the factors today that really contribute to this wide gap in access to healthcare for Black Americans, and what environmental factors contribute to these racial health disparities?
Well, as a representative of someone working in an under-resourced community, I will cite a couple. You heard me talk during the clip about the importance of insurance coverage and about the type of insurance coverage you have. So communities that are low income are dependent on public insurance, and the providers in the community are dependent on that same public insurance that typically does not pay enough to cover the cost of delivering quality health care. Therefore, you have a severe shortage of providers in these communities. From a historical perspective, it's also linked to a history of segregation, of redlining, of housing covenants that cause these communities to evolve over time as concentrated communities of poverty that then, fast forward, are not able to sustain the infrastructure that is necessary to support health, both the healthcare services and the other social determinants of health, like access to healthy food.
So I would add that again, these are long historical problems. So one of the things I like to talk about in my classes are the fact that Rebecca Crumpler, who was the first African American woman to get an MD from Boston University right at the end of the Civil War, goes to Richmond to see what she can do to help the newly freed peoples, Black peoples. And one of the things that she notices, especially after the government had set up the Freedmen's Bureau, Medical Bureau, to help these people who were now ostensibly free, but had no way, many limited limitations on how they could take care of themselves. And as she observed the health crisis that presented, she said, you know what? Now that we're free, the government should provide some kind of health care because we're citizens now and we deserve that. And the government did not respond in a positive way to that request. And I think that's important to note that in the late 19th century, that's not the response of the federal government. But then certainly by the late 1899 or so, when W.E.B. Du Bois first writes the Philadelphia Negro, where he does this extensive first sociological study, brilliant, still important work that examined the conditions of life for Black people who lived in Philadelphia. And again, he says, if tuberculosis is supposed to be about race, then you have to show me what it's about. Because what he could see was the conditions that Black people were forced to live in. And there were ways in which observers outside of Black communities seem not to be able to put those two things, the two and two together, and say conditions of life produce ill health. And so the struggle through the 20th century has been to get access for really good healthcare for people who live in conditions where and have economic circumstances, environmental circumstances where they and other economic circumstances that make it difficult for them to get proper healthcare. That's a question and a problem that this country has failed to provide adequate solutions to.
And I would just add that we now use the term social determinants of health to talk about this context. The context and its problems have always existed for us. And I find it helpful to think about the implications for healthcare inequities, not just health inequities. And
Yes.
that is inequities in accessing care. And then within the healthcare system, even among people who all have insurance, for instance, the ways in which there can be segregated care, tracking in care, just as we see tracking in, for instance, education, public education. So these things uh, exacerbate well-being. And unless we look more closely at it, we'll miss the ways that these happen along racial lines. That it's a manifestation of the ways in which racism is operating structurally, societally, and institutionally.
And Ralph, if I can make a plug for your audience who is interested in going deeper on the issue that Dr. Ford just identified of healthcare access and unequal treatment, the National Academy of Medicine published the 20th anniversary update to their seminal work, Unequal Treatment, called Ending Unequal Treatment, that is all about the healthcare system and the larger societal forces that contribute to health disparities and healthcare inequities. So I'd highly recommend that.
Thank you all. And as a quick follow-up and transition to that point, I'd love to sort of talk about some of the solutions. And I know Stanley in the film, we do spend a bit of time talking about some of the ways in which we can think about building a more equitable future with regards to access to healthcare, with regards to increasing and improving health outcomes for Black Americans. Could you speak to sort of what you discovered with regards to solutions? And I'd love to hear from the rest of the panel as well with regards to sort of some of the solutions that you've seen in your work and also in your experience in doing research on racial health disparities. Oh, Stanley, you're muted.
I said I'm gonna have to punt to some of the good doctors here on the solutions.
Well, I'd be happy to address that since that is, the work that I do on a daily basis. And it includes advocating for insurance coverage for everyone and quality insurance coverage for everyone, advocating for investment in primary care and prevention and disease management. It includes training more Black doctors so that we have a workforce that looks like the population and that looks like the people that are being treated. And it also includes policies, social policies that create a more robust social safety net. So, for example, we are taking better care of our population that is unhoused and, not making it impossible for them to access healthcare. So I think those are all part of the policy work that those of us who are interested in addressing the sort of systemic causes of healthcare inequities and disparities are working on.
Well, I would add to that is that, we have to begin to have more critical attention to the failure of certain kinds of policies. If policies are that relate to healthcare are not serving all the American people, then I think we ought to be talking about that far more than we have been in the past. I certainly think about the fact that at the beginning of the COVID epidemic, I just finished teaching a course on COVID. Finish tomorrow is our last class. And the students are asking real questions. If we've talked about the history of tuberculosis, we've talked about the history of HIV and AIDS, and we get to COVID, and the students are asking a very good and basic question. So if we knew all that about how to think about tuberculosis and AIDS, why are we in where we are right now? And I think in part it has to do with not holding institutions, policymakers, politicians, federal agencies accountable for making sure that, when something like a COVID epidemic, pandemic happens, that our policies are consistent with the view and the principle that we have to take care of everybody. We have to try to take care of everybody. And the fragmentations in our society are ways in which that we continue to marginalize certain groups and certain communities, and certainly Black people have been subject to this. Is a long history of that. And it's very hard to explain to students why that is still the case in the 21st century. So I do think the sort of, maybe I'm practicing my lecture for tomorrow, the last thing I'm going to say. We have to hold people accountable, because it's very difficult to justify the continuing and persistent institutional, systemic, and structural inequality that leads to the kinds of health outcomes that African Americans, peoples, and other marginalized communities continue to experience.
And if I can say, I agree with Dr. Hammond 100%, that it's a lack of will as well. That's one of the things that we identify in the unequal treatment book as a precursor to solutions, is having the political will to address the things that we've known for a long time and that we could implement and scale to start to make changes. And accountability is, key to getting those things done.
I would add also, that's so important that the field itself, our institutions, our healthcare institutions, it actually needs to be the subject of research. We need to study further because, again, people have been studying this, exactly how these decisions are made, for instance, exactly how the mechanisms by which these, inequities are produced. I'll put it that way. Um, and and that, in fact, is the basis for those declarations now that racism is a public health problem and that we need to address racism within the healthcare system. Those understandings now are based on the science. And so part of what we need to do in terms of accountability is simply hold our institutions and our professions, our politicians, and our communities to the very missions and vision that we already have it in existence, the statements that we already proclaim. If we merely adhered to those, we actually would eliminate a lot of the inequities. In terms of other more proximal potential solutions, there have been studies that have shown that if we do things, for instance, like blind providers to the race of the patients with whom they're working, prompting, for instance, using AI, for instance, to prompt them to essentially circumvent providers' implicit biases, that they end up reducing disparities, treating patients more similarly. And not only do they reduce disparities, but in some cases, they have actually improved health for the overall population, regardless of race and ethnicity. So we have educational work to do. The public needs to know that disparities that affect Black women or other Black populations are not going to stay within the Black community. There are costs borne by our entire society. And that's not just true with Black people. It's true with various groups, including, for instance, immigrant populations. And we could think about the many dominoes that will fall if we're not treating all people in our society, the lives and well-being of all people in our society is absolutely valuable.
Great. Thank you all so much. And well, we're going to transition soon to our audience Q&A. Again, if you would like to submit a question for the Q&A, please use the Q&A function at the bottom of the Zoom window to submit your question. But before we transition to that, I just want sort of a final statement around sort of what do you all hope is the impact of this film? And I'll start with you, Stanley.
Sorry, I keep muting myself because there's so much noise in the background here. Um, I hope that people watch the film and just start thinking about healthcare in a different way, and start thinking about the inequities in healthcare in a different way. Um, it's so easy not to think about, healthcare until you yourself or your family needs it. But I think we need to think about it, and also not be scared of the times that we're living in. I think that we're not talking, we haven't talked about that, but we're living in a very strange time. But it can't stop us. It can't make us, afraid to push for what we know is right.
Thank you, Stanley. Dr. Ford, Dr. Hammonds, Dr. Batchlor, your thoughts?
Personally, I hope that it will open eyes, raise awareness, and result in people being more supportive of the kinds of actions and policies we need in order to overcome the legacy and the persistent inequities in our system. So that's my hope.
I agree with those. And also, as perhaps a love letter to the Black community, I want Black people to know that we do what we can. Communities do what they can with the information and the tools we give them. And it is our responsibility as public health and other health-related professionals to provide the best tools for our communities. Too often, members of our communities feel like they have done something wrong. And I want to put that onus on us, on our professions, and on our institutions. So I think that this film helps to convey that.
Well, I certainly agree that my hope is that the film will convey all the expressions that we've tried to make. And in the end, I just want people to understand that it doesn't have to be this way. It really doesn't. We can make a better future. We can make a different and more just future. But understanding some of the ways in which we got to where we are right now, and what we need to do to move forward, I would just like to think that, we won't have another generation of folks who look like us around this Zoom screen telling stories about how bad it was back in the 21st century. I mean, we can stop this. We really can. And I do think the more we can talk about these issues, the more we can show the good work and incredible work that people are trying to do, and to address a situation that does have a solution. We have good solutions that we can bring to bear on this, and we can make it different, and we can make it better.
Great. Thank you all so much for these wonderful responses. So now we'll transition to a few questions from our audience. Thank you to everyone who submitted questions. We'll try to get to as many as we can in the time that we have remaining. But the first question is around some of the medical algorithms. So how do we delicately differentiate between medical algorithms like average weight, height, blood pressure, when and how menstrual cycles happen, that is typically measured through white patients versus flat out racist medical standards? So how do we differentiate between those two?
I guess what I would say is that I think as scientists, we now recognize that race is a social concept and not a biological reality. So basing algorithms on something that is not scientific is not going to get us where we need to go. And so, my perspective is that we need to go back to science and, correct those errors and embed what we're doing in good science.
Totally agree.
Thank you. Oh, Dr.
There's
Ford.
nothing to add to that. There is nothing to add to that.
All right. Our next question is about prevention. How can we continue the effort to not only improve healthcare, but also to create more preventative measures? For example, the lack of healthier food options in Black communities. So, can you share any thoughts on sort of preventative measures that can be sort of that can address some of these healthcare disparities before folks are interacting with healthcare providers?
The behavioral sciences have really focused on individual level prevention. That is healthy diets, how I eat, how I exercise, how my family eats, exercises. I would really like us to shift our attention to the population level, because there is where the leverage really is. If we have policies that make it possible for me to eat in accordance with the existing guidelines, or eat in ways that are healthier, or exercise in ways that are healthier, then I think we'll see the dramatic shifts in whole population level prevention, rather than right now the sort of emphasis again and again and again on individuals uh, approaching their own well-being from a preventive perspective. Just one example I'll cite is, in fact, the COVID pandemic, where the public health community, in some respects, did not follow through with its responsibility to ensure optimal health for all in terms of prevention, instead relinquishing that responsibility to individuals, as if individuals have all the tools and information necessary to do that, with a sort of, well, if you think you're at risk, you take care of yourself, good luck kind of orientation.
Mm-hmm.
So, yeah.
I would say that as we are doing a better job of connecting the dots of the social determinants of health, we're also seeing health systems and hospitals and payers pay more attention to the social determinants of health, things like transportation and food and exercise, environmental safety, exposure to pollutants, housing insecurity, and starting to invest some of the resources that we would otherwise be investing in rescue care, going upstream of those rescue interventions and starting to invest more of those funds in addressing the social determinants of health, of creating more healthy communities and opportunities for people to eat healthily, to grow up healthy, so that we're not then trying to rescue them on the back end once they get sick. So I think that as we become more aware of the importance of those things, and more willing to address them, we're starting to see our resources move around a little bit.
Yeah, and it's really important that those resources move around, because I think we ought to be asking the question, what makes good preventive healthcare possible? It's not if when people have to travel long ways to where they work, or what kinds of food are available to them at places where they work, neighborhoods that don't have big box stores, or neighborhoods that do have big box grocery stores, and the prices are so incredible that it's very difficult. But I do think one important thing that I've noticed, and I've learned this from my students, social media can play a very, very important role. And so people sharing recipes, sharing exercise regimens, talking about what they do in their communities. Groups like Girl Trek that gets people out on weekends, and people walk together, exercise together, form community together, talk about these things. I think these are important new kind of social activities, and being, sort of made visible to lots of people through social media. I think there's a way in which we ought to use social media a lot more to think about the creative ways that we can also sustain ourselves as communities, but also never forgetting that there are some deep systemic structural things that are going to take more than just us hanging out together and eating better. It's going to take a lot more than that as well.
Yep. Just to give a couple of concrete examples of how the health system is doing a better job, we run a hospital and a health system, but we are providing fresh produce to our patients who have food sensitive conditions. We provide transportation so that our patients can get to their appointments and not be worried about, how am I going to get to my appointment? We take our health services out to where our unhoused patients live, so that they don't have to navigate their way into the health system in order to get health care. I think these are all ways that we can support better prevention and supporting the health of our patients and our communities.
Absolutely.
Great. Thank you all so much. We'll try to fit two more questions. This question is about practices for doctors. So, do you know of any initiatives to help doctors finance or begin practices in underserved communities? Are there any projects that help financially support providers to keep them in communities of need and not move due to better economic opportunities in more affluent areas?
Well, I think that you've just put your finger on a huge problem, which is, we can invest in training more um, physicians of color, but when they finish their training, where are they going to work that they will be able to give back to the communities that motivated them to go into medicine in the first place? And one of the challenges we see in communities like mine is that they can't afford to come and practice here. The reimbursement rates that our public insurance programs provides are too low. They graduate from school with debt that they have to repay, and it simply, doesn't work. So I think that we need to think more about how we get our students through school in a way that doesn't leave them encumbered with debt. But we also have to think about the reimbursement rates and the investment in infrastructure in communities like ours so that the physicians that are motivated to do this work can actually go and do that work and not end up working, somewhere else that doesn't actually need additional providers, which is often the case.
Great. Thank you so much. So unfortunately, it looks like that's all the time that we have for this discussion. I'd first like to thank you all for joining us for this incredible conversation. Thank you to our panelists. Critical Condition Health in Black America will premiere tomorrow night on PBS at 9 p.m. Eastern. Please check your local PBS station listings to confirm the time. The film will also be available to stream on the Nova website, pbs.org/Nova. You can find it streaming there. It'll be available to stream actually starting tomorrow morning. So if you want to get in a little bit early, you can tune in and log on tomorrow to begin streaming the film. It's also going to be able to stream on the PBS app. And so that's accessible as a mobile app, but also on most web-based platforms on through TVs and through other means as well. But thank you to our esteemed panelists for sharing their insights, their research on this issue. Thank you to Stanley Nelson, the Firelight Films team, and my colleagues at Nova for their work on this timely and important film. Thank you to everyone who joined us today. We really appreciated you all participating and sharing your feedback and your thoughts and your questions. This is a really exciting moment coming at a very important time to be having this conversation. And so I thank you to everyone who's participated in bringing this film to life. Hope you all enjoy the rest of your evenings and look forward to tuning in with you all tomorrow evening. Bye-bye, everyone.
Thank you,
Thank you.
and congratulations.
Thank you.
So much.